Hi everybody, welcome to our module on other gram-positive bacteria. So this is our algorithm for gram-positive bacteria, and in other modules I discussed staph and strep, and so what we're going to do in this module is talk about actinomyces and nocardia and also the gram-positive rods. So we're going to start by talking about Clostridia. So Clostridia are a family of bacteria and they all share some features that you should remember. They can all form spores. All of the Clostridia are obligate anaerobes, and they all make a toxin. And there are 4 of them that cause disease that you need to know about. The first one is Clostridium tetani, which causes tetanus. The next one is Clostridium botulinum, which causes botulism. Clostridium perfringens causes wound infections and food poisoning. And finally, Clostridium difficile causes diarrhea after antibiotic use. Clostridium tetani is found as spores in the soil, and these spores enter the body usually via a penetrating injury. The classic scenario is someone who's walking barefoot and steps on a rusty or dirty nail or gets a splinter. Once the spores get into the body, they germinate into bacteria and tetanus toxin is produced. Tetanus toxin is called tetanospasmin, and you should remember that it has the word spasm in it because, as we will talk about on the next slide, patients who are exposed to tetanus toxin will get a spastic paralysis where their muscles are very rigid. The tetanus toxin travels to the spinal cord, and in the spinal cord it blocks the release of glycine and GABA by inhibitory neurons. These are called Renshaw cells, and they're inhibitory spinal cord interneurons. So when you inhibit inhibitory interneurons, what you get is overactivity of the nervous system, and that's what leads to the rigid paralysis characteristic of a tetanus infection. So the symptoms are spasms and muscle contractions and rigidity, and there are a couple of classic symptoms you should know about. One is called trismus or lockjaw. This is when you can't move your jaw. Another one is called rhesus sardonicus. This is a forced grin from spastic facial muscles. You can Google this and see pictures of it. I always think of it as looking like the Joker in Batman. It's someone with a permanent smile because their muscles are contracted in their face and they can't relax them. The treatment for tetanus is to debride any wounds that are present. The antibiotic that's usually given is metronidazole. It's not clear if the antibiotics help very much, but because it's a serious illness, the antibiotic is always given. There is an immune globulin that will bind circulating toxin that can be given. Now, this will prevent circulating toxin from getting into the nerves, but it won't do anything for the toxin that's already been taken up by those Renshaw cells. What you then have to do is give people benzodiazepines or neuromuscular blockers until the toxin wears off. Luckily, tetanus is very rare in the modern era, and that's because there's a vaccine made up of the tetanus toxoid, and this is given to anyone who has a wound where they may have been infected with the bacteria, and then they never go on to develop tetanus. The next Clostridium we'll talk about is Clostridium botulinum. This is a ubiquitous organism. It's found in soil, in vegetables, fruit, and seafood, and it makes heat-resistant spores that can survive up to 100 degrees Celsius, and this is one of many reasons why you need to cook your food well so that you don't get sick. Botulinum toxin is another neurotoxin like tetanus, and it works at neuromuscular junctions, and it prevents acetylcholine release, and this means there will be no muscle contractions. So the result is a floppy paralysis with flaccid muscles. So this is in stark contrast to tetanus. Tetanus gives you a rigid paralysis. Botulism gives you a flaccid paralysis. And one thing that's high yield to know for step 1 is that there are many different variants of the toxin produced by the bacteria, and some of these are carried by bacteriophages, so the DNA is not found in the bacteria itself, but instead is found from a virus that infects the bacteria and delivers the ability to synthesize the toxin. There are 3 types of botulism: the food type, the infant type, and the wound type. So the food type is what usually happens to adults when they ingest the toxin directly. This happens when people eat undercooked food. A classic scenario is to eat undercooked canned food. The canned food is an anaerobic environment inside the can, and this is favorable to the bacteria. And what you'll often see are multiple sick adults after a meal who ate something that came out of a can. The second type is the infant type, and this comes from ingestion of spores. So it's different from the adult type where people ingest the toxin. In this case, babies ingest the spores, and then the spores go on to germinate and grow in the intestine. And a classic scenario here is a baby who's been fed honey. Honey is sometimes infected with spores of botulism. And then the third type is a wound infection. If you have a dirty wound and this bacteria gets inside, it can grow and cause an infection. So the symptoms of botulism occur about 12 to 48 hours after you've ingested the bacteria or been exposed to the toxin. And the symptoms are remembered by the mnemonic, the 3 Ds: diplopia, dysphagia, and dysphonia. So what this means is that the muscles of the head and neck are the first to be affected. So patients get diplopia because the eye muscles get weak and their eyes get out of alignment. They get dysphagia and have trouble swallowing or have trouble speaking. The diagnosis is often clinical, but there are some toxins that can sometimes be detected in the stool if you suspect it. And the treatment is to give an antitoxin that blocks circulating toxin, but just like with tetanus, this can't block the toxin that's already in the nerve, so you have to support patients until the toxin washes out. Sometimes they need to be on mechanical ventilation or need other types of support until the toxin is gone from the body. Clostridium perfringens is the next Clostridium we'll discuss. This is also widespread in nature. It's especially found in soil. And this can do two things. It can infect dirty wounds and cause gas gangrene, and it also can cause food poisoning. So gas gangrene is also called clostridial myelonecrosis, and this happens when a traumatic wound compromises the vasculature, and this creates a favorable environment for anaerobic growth. So without good blood supply, there's less oxygen, and the bacteria likes this because it's anaerobic. Clostridium perfringens secretes a toxin that's helpful for gas gangrene called alpha toxin. This toxin destroys muscle tissue and causes hemolysis, and this helps create that favorable anaerobic environment that the bacteria likes. One thing that's high yield to know about this toxin is that it's a phospholipase that acts on lectin. That's called a lectinase. And this means it can degrade phospholipids in the cell membranes, and this is what helps it to break down muscle tissue and cause hemolysis. Gas gangrene is severe pain at an injury site. Usually within 24 hours, the skin gets tense and tender. This is a picture of a patient with gas gangrene of the leg who's going to undergo amputation. It's a very, very serious infection. There can be systemic toxicity like fever, hypotension, and shock. You diagnose it by finding gas at the injury site on imaging, or sometimes there's a finding called crepitus. This is when you can feel little bubbles of air inside the wound. The treatment is surgical debridement and then broad-spectrum antibiotics, because these wounds often have not just Clostridium but also other anaerobes and gram-positive bacteria, and so this is why broad-spectrum antibiotics are used. Clostridium perfringens can also cause food poisoning, especially if you eat undercooked meats. So the spores get ingested and then the bacteria grow and produce toxin. This gives you watery diarrhea, which is what a lot of forms of food poisoning can give. What's special about Clostridium perfringens is that the diarrhea has a late onset of 8 to 22 hours. The reason for this is because you're ingesting the spores, so you don't get sick until the spores have time to germinate and produce toxin. Now contrast this with food poisoning from Staph aureus or Bacillus cereus. In both of these bacteria, what you ingest is a preformed toxin, so you get sick much quicker, usually in about 3 to 6 hours. And it's high yield to know this difference between early onset and late onset diarrhea in food poisoning as pertains to Clostridium perfringens versus other bacteria like these two here. And the final Clostridia that we'll discuss is Clostridium difficile, and this is the Clostridium that you're most likely to encounter in actual practice. It's very common, especially in patients in the hospital. C. difficile forms ubiquitous spores that you can find in nature anywhere, especially in the soil, just like other Clostridia. And ingestion is not harmful with normal GI flora. So if you were to ingest a bunch of Clostridium difficile, you would not get sick at all. And the reason you wouldn't get sick is because your normal flora would prevent overgrowth of the bacteria. So it would harmlessly pass through you and never vegetate and grow inside your colon to make you sick. What C. difficile causes, and the reason you see it so much in the hospital, is it's associated with antibiotic colitis. So if you take antibiotics, this alters the normal gut flora, and this creates a favorable environment for C. difficile. So many hospitalized patients are on antibiotics for various infections, and they're also exposed to C. difficile. And what happens is they then get this antibiotic-associated colitis from this bacteria. C. difficile is not invasive. The disease is entirely via two toxins. The first toxin is called toxin A, or enterotoxin, and it causes a watery diarrhea. The second toxin is called toxin B, or cytotoxin, and this causes cell necrosis and fibrin deposition. And toxin B is about 10 times more potent than toxin A, and there are strains that lack toxin A that still make people sick, so toxin B is the most important toxin of the two. Both of these toxins bind to GI cells and are internalized, and one thing that's high yield to know is that they destroy cytoskeleton elements of the GI cell, so they break down the infrastructure of the cell. And this is what leads to formation of the pseudomembrane in the colon, which we'll talk about in a minute. C. difficile colitis results in massive watery diarrhea, and in a board question and also in real life, this is going to be in someone who's recently been on antibiotics. It may be someone who was put on antibiotics as an outpatient, or it sometimes occurs in people who are in the hospital and have been on antibiotics. If you do an endoscopy, which is rarely done, you'll see something called a pseudomembrane. This is a white-yellow plaque in the colon, and it's caused by ulcers in the mucosa and fibrin deposition and inflammatory cells, and all this is the result of the toxin. C. difficile colitis is sometimes called pseudomembranous colitis for this reason. And the way you diagnose a C. diff infection is by detecting presence of toxins A or B in the stool of a sick patient. There are two antibiotics you can use to treat C. difficile colitis. The first one is metronidazole. That will cover C. diff. Remember that metronidazole is used for anaerobes below the diaphragm, and C. diff is an anaerobe and it occurs in the colon, which is below the diaphragm. The other option is to use oral vancomycin, and I have the word oral capitalized here. Normally we never give vancomycin orally because it's very poorly absorbed, but in this case we want it to be poorly absorbed so it stays in the colon and kills the C. difficile bacteria. There's other therapy that's sometimes used for patients who have severe or recurrent C. diff. Sometimes surgery is done on the colon, and there is a new treatment modality called a stool transplant, which sounds kind of gross, but you introduce stool with the healthy bacteria and it sometimes eradicates the C. difficile colitis. The next gram-positive we're going to discuss is Corynebacterium diphtheria, which causes the illness diphtheria. Diphtheria is very rare in the modern era, but decades ago many children used to develop diphtheria, and some of them would actually die from the illness. Diphtheria has a couple of special features that you need to know, especially for step 1. You need to know about its exotoxin, and you need to know about some of the unique lab diagnostic techniques used to identify the bacteria. So diphtheria exotoxin is synthesized and secreted from DNA that is not part of the bacterial genome. The DNA for diphtheria exotoxin is carried by a phage called beta-prophage, and this is a lysogenic phage, which means that the DNA from the virus gets incorporated into the diphtheria bacteria's DNA. Once it has this DNA, it can synthesize the toxin, and what the toxin does is it inactivates elongation factor 2. And elongation factor 2 is necessary for protein synthesis, and I talk about this in more detail in the module on virulence, but elongation factor 2 gets a molecule added to it called ADP ribosol. This is called ADP ribosylation, and once EF2 has been ADP ribosylated, no protein synthesis is possible. Corynebacterium are curved gram-positive rods. This is a picture of some of them over here, and you can see that they are dark purple because they're gram-positive, and they look like small curved rods. They're often described as having a Chinese character distribution because the little purple rods look like Chinese letters sometimes. You have to use special culture media in order to identify Corynebacterium, and the two media that are used are Loeffler's media or Tinsdale media. Tinsdale media is also called a tellurite plate, and I talk about these two media in more detail in the module on bacterial culture. On Tinsdale media, the bacteria will reduce tellurite to a substance that's black, so it will form black colonies. And on Loeffler's media, Corynebacterium will grow as metachromatic blue-red granules. There's also a special test for detection of the toxin called an Ehrlich test. This is where you plate an unknown bacteria on an agar plate with antitoxin impregnated filter paper underneath. If the unknown bacteria secretes diphtheria toxin, then the toxin will precipitate and it can be visualized. So this is an example of what an Ehrlich test might look like. So this circle I've drawn in the middle of the screen is a petri dish with some agar, and the rectangle in the middle of the agar dish is filter paper impregnated with diphtheria antitoxin. So what you then do is you take an unknown strain of bacteria and you streak it across the dish. Let's say these are two unknown strains that I've streaked across right here, represented by my blue line. If one of the strains produces diphtheria toxin, it will precipitate out at 45-degree angle lines like this, and you can see that after it grows in the incubator. So what I've shown on the bottom of the slide here is an example of a positive Ehrlich test. On the top might be a bacteria that is not diphtheria, and it's a negative Ehrlich test. And years ago, this was done when children had sore throats. You could swab the throat and then grow the bacteria and plate it on an Ehrlich test. And if these 45-degree lines precipitated out, then you knew that the child had diphtheria. And you can Google an Ehrlich test online and see lots of examples of a positive Ehrlich test and what it looks like. So the symptoms of diphtheria are a sore throat with fever and swollen glands, and classically there is a gray-white membrane present in the back of the throat in the pharynx. And the reason this is a serious illness is because absorption or dissemination of the toxin can cause a lot of serious sequelae. Patients can get myocarditis with heart failure, arrhythmias, and heart block, and this is the way children often die from diphtheria. You can get neuropathies if it gets into the brain, and you can get renal disease if it gets into the kidneys. Luckily, diphtheria is very rare in the modern era due to vaccination with a toxoid vaccine. The treatment for acute infection includes penicillin. This bacteria is generally sensitive to penicillin. And then to administer diphtheria antitoxin, this is called passive immunization. And then you also administer the toxoid vaccine, which is called active immunization. The next gram-positive bacteria we'll discuss is Listeria. Listeria is found in the soil. It's a facultative intracellular organism. And one thing to always remember about Listeria is it has some very unique mechanisms by which it moves. If you look at it under the microscope, you will see something called tumbling motility. You should search for this on YouTube and you can see examples of it. The bacteria tumble and move very rapidly around the petri dish. The other unique movement feature of Listeria is that it moves inside of cells from cell to cell to avoid any extracellular exposure or immune response. And inside of cells, it can actually take over the host cell machinery and polymerize actin to move. These are called generation of actin rockets because it moves very quickly inside cells using the host machinery. Listeria tends to infect people who have poor cell-mediated immunity, so newborn babies, HIV patients, organ transplant patients, all of these groups of patients have poor cell-mediated immunity. Adults can get sick from Listeria if they consume contaminated food, so it's often found in undercooked meat or unwashed vegetables, and it's classically found in unpasteurized cheeses and milk. So pasteurization is a process by which you warm up dairy products and then cool them off to eliminate bacteria. If you consume unpasteurized cheese or milks, you're more likely to get infected with Listeria. And it likes cold temperatures, so the milk and cheese are kept in the refrigerator, and this is favorable for Listeria. In newborn babies, they can get sick with Listeria from transplacental or vaginal transmission from the mother sometimes. We'll talk more about that in a minute. So let's talk about the illnesses Listeria causes. As I said before, adults who consume contaminated food can get sick, and they get gastroenteritis. It's usually diarrhea, nausea, and vomiting. It's usually self-limited and doesn't need to be treated. Listeria can cause meningitis in two unique groups, the very elderly and newborn babies. And again, that's because both of these groups of patients have poor cell-mediated immunity. And then finally, Listeria can cause infection in pregnancy. Pregnancy is actually associated with a very mild degree of immune system suppression so that there isn't an immune response to the fetus and the placenta. And sometimes women can get bacteremic in their third trimester. What happens is they get a flu-like illness with fever and chills, and it often resolves without treatment, and this can be from Listeria. But rarely this can progress to cause fetal demise or a newborn infection. So infection of a baby from a mother in pregnancy is called granulomatosis infantiseptica, which is a mouthful. And this is a severe in utero infection from Listeria. The baby develops disseminated abscesses or granulomas. Lots of organs can be involved, the liver, spleen, lungs, the kidneys, and the brain. The baby can develop skin lesions like papules and ulcers, and most of these babies will be stillborn or die soon after birth. And one thing to know is that the placenta shows a distinctive inflammatory pattern in babies who get this condition. There's inflammation of the chorion and the villi, and there are abscess formations. So what you want to look for is a mother who gets a flu-like illness in her third trimester and then loses the baby. One thing you should think of in that scenario is that it may be Listeria, because that's a bug that tends to make this happen. The next set of gram-positive bacteria are the bacillus organisms. There's Bacillus anthracus, which causes anthrax, which is usually skin or pulmonary disease. This has largely been eradicated by vaccination, but it is a weapon of bioterrorism because the spores can be released into a populated area and cause widespread disease. And then there's a bacillus called Bacillus cereus, which causes food poisoning. So let's talk about Bacillus anthracus first. One thing that's high yield to know for step one is this is the only bacteria with a polypeptide capsule. Most bacteria that have a capsule is made up of polysaccharides, not anthrax. B. anthracus capsules contain D-glutamate, and this limits and prevents phagocytosis. It's found in the soil, and it likes to infect farm animals like cattle, sheep, and horses. Of course, it can also infect humans. But one thing to know is that farm workers may be at risk, and we'll talk more about that in a minute. As I said before, the spores can be used as a bioterrorism weapon, and anthracus produces two toxins that cause disease, edema toxin and lethal toxin. Let's talk about the two anthrax toxins. The first one is called edema toxin. It contains edema factor, which is the active component. And edema factor mimics adenylate cyclase, and it increases cyclic AMP inside of cells, and this leads to fluid secretion, and that's why it's called edema toxin. Lethal toxin contains an active component called lethal factor, which is a protease, and this inhibits cell signaling and causes apoptosis, especially if some immune system cells which are necessary to fight off the bacteria. So let's talk about the cutaneous disease first. This happens when spores enter the skin through cuts or abrasions. The bacteria vegetate and grow, and a painless black ulcer will form. This is a picture of one down here. It can rarely progress to bacteremia and death. And one thing that's very high yield to know is there's usually a little area of edema surrounding the ulcer. You can see it right here. I'm tracking it with my pen right now. It's a little bit of swelling and edema around the ulcer. And that comes from the toxin edema factor made by the bacteria. And you can treat this with antibiotics like ciprofloxacin, doxycycline, and clindamycin. The pulmonary form of the disease is the more dangerous form. This is called wool sorter's disease because people that work on wool from farm animals would inhale the spores and get sick. It happens when you inhale the spores and they get into your lungs. First, flu symptoms start, but then it rapidly progresses. It can cause bleeding in the lungs, pulmonary hemorrhage. It can cause inflammation of the mediastinum, and then it can cause shock and death. And a classic finding of pulmonary anthrax is a widened mediastinum. Let's look at this chest x-ray on the left right here. This is the mediastinum here with my pen, and it's relatively narrow and normal appearing. Now let's look at the one on the right. This is the mediastinum here. It's much, much wider than normal. Now, the classic cause of a widened mediastinum is an aortic dissection, but this would be a patient with flu-like symptoms and a possible anthrax exposure. If they develop a widened mediastinum, they have mediastinitis from the anthrax bacteria. It's very difficult to treat this. Usually a multi-drug regimen is given, and also antitoxin is administered. The other bacillus is B. cereus, which causes food poisoning from enterotoxins. And the classic case is someone who eats undercooked or reheated rice. It's sometimes called the reheated rice syndrome. So these bacteria are frequently present in uncooked rice, and the heat-resistant spores can survive cooking. So if you undercook rice and then leave it at room temperature for a while, the bacteria can multiply, and then when you eat it, you are going to ingest the enterotoxin and you're going to get sick a few hours later. One thing that's important to know is that the sickness here is caused by directly ingesting the enterotoxin, not by ingesting the bacteria, which then secrete the enterotoxin in your stomach. They like you to know that distinction for step 1. So there's 2 types of B. cereus food poisoning. The first type is the emetic type. This happens from direct ingestion of the toxin cerulide. Patients get abdominal cramps and nausea and obviously vomiting, usually not with diarrhea. That's why it's called the emetic type. And this occurs a few hours after ingestion, and this classically occurs in rice dishes, as I said before. The other type is the diarrheal type, which has abdominal cramps and diarrhea, obviously, based on the name. It occurs slightly later, about 8 to 16 hours. It's caused by secretion of several enterotoxins that are heat labile, which means that they are destroyed by heat. So if you cook the foods well, you will reduce the risk of illness. And this often happens not from rices so much, but from eating meats and vegetables and sauces and things like that aren't properly cooked. The last 2 gram-positive bacteria we'll discuss are actinomyces and nocardia, and we'll start with actinomyces. This is part of the normal oral flora. It also can be found in the female genital tract. It is anaerobic, and it clusters into long filaments resembling fungi. In fact, years ago, people used to think it was a fungi until they were able to analyze it and find out that it actually had characteristics more consistent with bacteria. This causes 2 problems you should know about. The first are head and neck abscesses. You can imagine it's normal oral flora, so it can get into the soft tissue and form an abscess. And it can also cause IUD infections. So women who use intrauterine devices for contraception can get abscesses and infections from this bacteria because, as I said, it's found in the genital tract. The classic description of actinomyces infection is to have someone who's got dental work or trauma to the face and then has a facial mass present on exam. It often has a yellow center because this bacteria tends to form yellow sulfur granules, and it's often draining pus. And this can be treated with penicillin, and you usually also have to drain the abscess to get the bacteria to completely clear. Nocardia is also a branching filamentous bacteria. Like actinomyces, it also resembles fungi. One unique thing about nocardia is that it is acid-fast. Other than mycobacteria, this is the only bacteria that is acid-fast that you need to know about. It produces urease, and this can sometimes be used to identify the bacteria. It's also an obligate aerobe, so it loves the lungs, and that's one way to remember that it can cause pulmonary infection. We'll talk about that in a minute. It's found in soil, but people can inhale it, and that's one way they get sick. So nocardia is overall a very rare cause of infection, but it can potentially cause 2 illnesses depending on whether or not your immune system works. It can cause pneumonia in patients who are immunocompromised. So you want to think of this in patients with HIV/AIDS. They can inhale the bacteria and get pneumonia. And it doesn't really have any classic findings. There are lots of different potential radiology findings. The way you're going to recognize this in a board question is that the patient's going to be immunocompromised, and then the description of the bacteria is going to be one of these branching, maybe acid-fast bacteria like nocardia is. If you have a functioning immune system, you can get a skin infection from nocardia. It often invades the skin when people are gardening or farming because, remember, it's found in the soil. And once again, there aren't really classic manifestations. There are lots of different potential findings in the skin: ulcers, cellulitis, nodules, or abscesses. Once again, in a board question, this is probably going to be someone with a skin infection and then the bacterial description will fit with nocardia. It can very rarely cause some other infections like brain abscesses and bacteremia, but this is very uncommon. And the drug of choice to treat nocardia is to use Bactrim, which is also called TMP-SMX. And that concludes our module on other gram-positive bacteria.